Hi, my name is Jessica and I am a nursing student at the University of Michigan. I am practicing my clinical skills and assessments on the telemetry unit of the Veterans Hospital in Ann Arbor, Michigan, and I am going to present a patient to you. The patient is an 86-year-old Caucasian male and was admitted on March 20th, 2014. Patient works as an artist out of his home and has for many recent years. Patient's chief complaint was admittance due to a vehicle accident resulting in a wound on the interior side of his right lower leg. Upon admittance, he was diagnosed with congestive heart failure, atrial fibrillation, and renal disease. Patient has a medical history of chickenpox and shingles during childhood and a history of a rose fever allergy. All immunizations, including flu and pneumonia, are up to date. Patient has no history of hospitalizations or surgeries. For the functional assessment, patient reports he has quit smoking 44 years ago and has been sober for 4 years. Before hospitalization, patient was a frequent runner and had a rigorous weekly exercise routine. Patient has some mild sleep disruptions throughout the night and is not on a normative sleep schedule when at home. Patient's psychosocial data would consist of 6 children, 16 grandchildren, and 1 great-grandchild. However, much of his family lives out of state. Patient attends church regularly and the highest degree of education is graduating high school. Patient reports that he does not attend healthcare appointments on a regular basis, but only as needed. Family history indicates that the patient's mother was also diagnosed with congestive heart failure and had an addiction to alcohol. Father's medical history was unattainable. The patient's blood pressure is 138/66. Patient has a pulse rate of 74 and a respiratory rate of 18 breaths per minute. The first assessment performed was of the cardiovascular system. The contour of the chest is normal and there is no indication of heaves or lifts over the 5 key areas of the heart during inspection. The 5 key areas consist of the aortic, pulmonic, Erb's point, mitral, and tricuspid areas. These were then palpated with no lifts or thrills present. The PMI was also present and regulated during palpation. The 5 key areas were auscultated with the bell and diaphragm of the stethoscope, and sounds are present when the patient is sitting up and lying down in a supine position. S1 and S2 are heard in all areas. S3 is present and is typical in a patient with CHF due to fluid overload in the heart. S4 is not present at this time, but should be monitored due to the ability for it to develop as the patient's condition worsens. S4 can be present in a patient with heart failure due to stiff ventricles resulting from damage in the heart. S3 and S4 sounds can be hard to determine and should be monitored closely in relation to the tachycardia which can be present in heart failure patients. Bruit, murmurs, and regurgitation were not present but should also be monitored because the patient is at risk for developing these abnormalities. The second assessment performed was done on the respiratory system. The respiratory system is pertinent for assessment in a patient with congestive heart failure due to the buildup of fluid and lack of oxygen being produced. However, the patient's findings do not indicate severe abnormalities. The diameter is a normal 2-to-1 ratio and appears to be symmetrical. There are no injuries present and the contour of the chest is normal. Patient appeared to have mild shortness of breath when talking, but did not seem to be in much distress. This may be due to allergies or could be attributed to his CHF. No cough was present. The rate and depth of the patient's breathing pattern appear normal during inspection. There is no crepitus, bulging, tenderness, or cyanosis present during palpation. Tracheal position and expansion is normal. Tactile fremitus diminishes as normal and indicates no sign of consolidation in the lungs. All lung fields were auscultated anteriorly, posteriorly, and laterally with some wheezing present. Wheezing may be due to the patient's allergies, heart failure, or an indication of COPD. Patient was auscultated for bronchophony and the findings were a soft muscled sound indicating a normal finding. Egophony and whispered pectoral colloquy was not assessed. 2 other systems that would be important to assess based on the patient's conditions are the urinary system and the peripheral vascular system. These 2 systems would be assessed because of the patient's reason for initial admittance and the correlation between congestive heart failure and renal failure. The patient has an interior wound on his right lower leg due to the vehicle accident, along with edema of the extremities. Patient would be assessed for this system because there are no signs of redness and edema. The extremities would be further assessed for tenderness and warmth, as well as capillary refill. All pulses should be assessed and graded to make sure that the patient is having adequate blood flow throughout the body. Patient should be assessed for arterial and venous insufficiency and deep vein thrombosis. The patient is also at risk for arteriosclerosis and atherosclerosis. The urinary system would be assessed as well because of the correlation between renal failure and CHF. In a patient with renal failure, healthcare professionals would assess for the normal voiding pattern and frequency of that patient, as well as the appearance of urine and current problems with urination. They would then perform percussion of the kidneys to detect for areas of tenderness and also palpate for the contour, size, tenderness, and any lumps. Palpation of the bladder would also be performed along with examination of the urethral meatus for swelling, discharge, and inflammation. The patient's urine would be used to measure the volume and color and tested for specific gravity, glucose, ketone bodies, blood pH, and other important substances. A series of diagnostic tests would be administered to test the function of the kidneys, such as urinalysis, urine culture, cytoscopy, and blood tests. Currently, the patient is on 10 medications. The patient is on 80 milligrams of furosemide tablets every morning, which is a diuretic, and causes an increase in the output of urine from the body. The patient is on 25 milligrams of metoprolol tartrate tablets twice a day to treat his blood pressure. Patient is on 2.5 milligrams of zolpidem tablets every evening as needed for insomnia. Patient is on 25 milligrams of hydralazine tablets 3 times a day to lower blood pressure, and it results in decreased atrial blood pressure, decreased peripheral vascular resistance, and an increase in heart rate, stroke volume, and cardiac output. Next, the patient is on 2 milligrams of warfarin every evening to thin the blood and prevent venous thrombosis or pulmonary embolism. The patient is on a 0.5 milliliter subcutaneous injection of heparin every 8 hours, which is an anticoagulant that works to also thin the blood and prevent blood clots. Patient is taking 10 milligrams of cetrizine tablet every day as needed for his sinuses and allergies. Patient is on an albuterol inhaler every 6 hours as needed for shortness of breath. He is on 0.8 milligrams of tamsulosin capsules that are taken every night to relax the prostate and the neck of the bladder in order to help the patient urinate easier. Lastly, the patient is on flunisolide inhaler twice a day to treat his congestion, sneezing, and runny nose caused by allergies.